Let me start by asking a quick question. Raise your hand if you've ever experienced really significant itching yourself. Yeah, okay, and then you know what it's like. You can't do anything. I had hives from a medication, and I was the most miserable coot for 3 days I've ever been in my entire life. Okay, let me ask you another question. How many of you can think, while you're sitting here right now, immediately, of a patient in your practice who itches that's a problem? Yeah, everybody. All right, so there you go. So hopefully I'll give you a few tips. This is a really long talk. I'm going to have to do it really kind of quickly. I'll be around for the whole conference. If we don't get to questions while I'm doing this, then grab me. Okay, so I have no conflicts of interest to disclose. Here we go. Here's my objectives for what it's worth. That's fine. Okay, itch. What is itch? Itch is the unpleasant sensation that evokes the desire to scratch. That's how it's defined. Itch begets scratch. Okay. By the way, it's Pruritus, U-S, not I-S. And I was reviewing some consult notes from our residents at the Houston VA, because I have to review every single consult note that's written, whether I saw the patient or not. And I had one resident that kept writing Pruritus, I-S. And if you have trouble remembering, here's a little clue. I-S is usually inflammatory something, right? Pharyngitis, cholecystitis, and itching is often not due to inflammatory reasons. So it's the U-S, not the I-S. Please spell properly. Here's the pathophysiology of itching. So keep in mind, itch is not just pain that's wrong. It's a different sensation. It's carried on very specific fibers. If you think about itch, if I asked you, without showing you the slide, and said, had a piece of paper in front of you, and I said, write the mediator of itch, I bet every one of you would write histamine. And you're right, but look, there are all sorts of other things that mediate itch, including neuropeptides, some proteases, cytokines, substance P. It's interesting and it's important to know that. So for example, I've highlighted one in red, IL-31, interleukin 31, which is produced predominantly by activated Th2 cells, Th2 lymphocytes. So if you know that that's a mediator of itch, what can you do in the 21st century? You develop a monoclonal antibody that binds to it and doesn't let it work. And IL-31 is particularly overproduced in atopic dermatitis. And we have coming very shortly, not tomorrow or next week, but in the not too distant future, an anti-IL-31 antibody that makes atopic dermatitis patients cease itching. And what's the biggest problem with atopic dermatitis? They itch, they scratch. They're kids, they keep their parents up. If they're adults, they're miserable, they can't work. So knowing these various mediators is important, mostly from a potential therapeutic standpoint. The neuroanatomy, I'm not much of a neuroanatomist. There are afferent and efferent fibers. The important thing to know about this is that there are suppressing nerves that come from upstairs in your brain that tell you not to itch. And when that's lost, you may start to itch. And that's important in one of the classes of itching, which we'll get to. It's a little teaser. So scratching. Initially, scratching is really good. It produces a phenomenon called surround inhibition. So you scratch an itch and that actually activates certain receptors and nerve fibers that suppress itch. So scratching it initially is really, really good. It also activates pleasure centers in the brain. So scratching an itch is like having sex. It's kind of cool. In fact, this was recognized back in the 16th century. Look at what Montaigne wrote. Scratching an itch is one of nature's most wondrous things and the closest at hand. So you have your hand. Think of a few other things, but we won't go there. Okay, but here's the problem. After a while, it becomes a noxious stimulus. Itching where you can't reach becomes frustrating. Itching during the night inhibits sleep. It bothers you during work hours. And so it actually is a bad thing, but wait, it even gets worse. Then there's a thing called itch sensitization. The longer people itch, the more likely this is to occur. And what that means is almost any sensation is now interpreted as itch. Cold becomes itch. Hot becomes itch. Shirt rubbing over your back becomes itch. So it actually, instead of being pleasurable, is now really a bad thing. And so the net effect is itching is bothersome. A little itch, a little scratch, oh, that feels so good. But after that, when it becomes chronic, it's really a negative phenomenon. And so we're going to try and put itch in classes. And I think if you can do this, it immediately starts you along a diagnostic algorithm. And the correct diagnosis leads to the most effective therapy. So this is the way I like to look at itch. And I hope you'll adopt this way of thinking about itching. You'll do some of it rapidly and basically subconsciously. So the first thing is the itchy patient. Do they have a rash or don't they have a rash? Do they have something wrong with their skin that you can look at and see objectively? That's the first thing. The hard patients are in that second group, particularly hard. I itch. You look, there's nothing to see. Mrs. Jones, I don't see anything, but I'm itching. And so we'll get to those. So we have a rash, or we don't have a rash. And then from that, we have a rash that is diagnostic of and by itself, or we have something that's pretty nonspecific. So let's talk about the diagnostic of and by itself. So these are all the I've got an itch and I've got a rash diseases. It's not all of them, but it's the vast majority of them. Everything from scabies to lice to dry skin to atopic dermatitis. Herpes zoster usually hurts, not itches, but sometimes fungal infections, drug reactions, and so forth. Now, I could talk 3 hours on this little box alone, but I'm trying to get through all of this, so I'm going to select a few of these. And I'm going to start with dry skin, xerosis cutis. Lots of old people are dry. Young people can be too, but it's really a major problem in the more mature. I used to say elderly, but I'm now in that class. So it's more mature. And people who itch more at night. Why do they itch more at night? Is it a physiologic, biochemical thing? No, they have less distractions. There's just less going around in their world, so they itch more at night. It's particularly true. Why the elderly? Because as we age, all of us, if you stayed in a cave, I'm not talking about going out in the sun, which we usually talk about. If you just stayed in a cave and you aged, your skin would thin and you'd have more TEWL, that's transepidermal water loss. If you lose water from your skin, what does it become? Dry. If it becomes too dry, it becomes itchy. And also, if you just stayed in a cave and aged, the function of your sebaceous glands, which are supposed to produce moisturizing materials that protect you from losing water and actually keep your skin not from itching, those sebaceous glands stop functioning as efficiently as they did. And in places where you have low numbers of sebaceous glands, you got lots of them on your face, not too many on your shins. So in places where you have low numbers of them, if they stop functioning or reduce their function, then you're really more prone to dry skin and itching. And then you throw in not only the intrinsic factors, but extrinsic things like cold weather. Cold weather dries out the skin. Why? Not so much because of the cold, but because you walk in to a restaurant or a store or a school and you have piped-in heating. What does heat do? Evaporates water from the skin. You get dry. And then in the patient population that you all are taking care of, they might be dry because of other extrinsic things in a sense, right? They might be getting diuretics, as you've heard about, for their blood pressure. Or they might be diabetics and they're peeing out because they're getting anti-diabetic drugs. It's great, the ones that block the reabsorption of glucose. Well, you also can dehydrate your skin, not just dehydrate the rest of you. They may be alcoholics. Alcohol acts as a diuretic. Or they may be using a lot of soap. And patients naturally feel they can wash problems away. What does soap contain? Soap is supposed to clean. So it contains detergent materials that not only take off dirt, but also takes off natural moisturizers. So all those added to the intrinsic aging process is why older people itch the most. This is a picture of dry skin. It is really hard to photograph dry skin. It's one of those, you know it when you see it. Now, sometimes it can get really bad and it's easier to photograph, but this is the most common cause of itching, particularly in the more mature individual. Dry skin. It feels dry, it feels rough. You may have these little cracks that form. Sometimes it's very inflamed, it can be quite red, and then that's called xerotic dry eczema because it's now overtly inflamed and it itches like crazy. It can be really inflamed. It's also called eczema craquele. Craquele is cracked in French, and there's cracked porcelain. Look at that cracked porcelain. That's what it looks like on the skin when you have extremely dry skin that's usually very itchy and usually somewhat red. So if you have dry skin, and over 50% of those over 65 have dry skin, what do you need to do? You need to put something on to moisturize it. Now, traditionally, there have been 3 classes of moisturizers. Humectants that draw water into the skin from deeper tissues. Lactic acid is an example of one of those. Urea is an example of one of those. You can put stuff on that's just goopy, like dimethicone, cyclomethicone. It's a silicone-like thing that just sort of moisturizes in a sense. Or you can put on occlusives that keep water from evaporating. So that would be something like mineral oil or petrolatum. And that's the way moisturizers have been formulated, with 1 or 2 or 3 of those basic classes forever and a day. And here are some of my favorites, and all these are in the, and I'm going to show you brand names because I'm going to show you all the brand names, or many of them at any rate. These are some of my favorites. But this paradigm has changed recently, for the good, I might add, and this is how it's changed, and that's with ceramides. Ceramides are the major component of what we normally produce to moisturize our skin. And what ceramides do is they don't just lay on the surface. When you put them on, they are natural. And so what they do is they penetrate right through the outer layer, the stratum corneum of the skin, and they start circling individual cells with protective materials. So it's not just goop on the surface, it's actually penetrating, and it goes, these have been radio-labeled, we know this is what they do, and so they go down and they circle individual cells. And they're very, very helpful in that way. They are the best mimicker because they are, in fact, the major constituent of what we normally should be producing. So I've listed essentially all the ceramide-containing moisturizers as of December 2016. I'm sure there will be more, but these are really superior because in addition, most of them have a little of the humectant, or they have a little bit of occlusion, or they have a little bit, but the real thing, in addition to those, they contain ceramides. And this one in particular, and again, I have no financial interest in any of these products. This Advancer is not really a happy event. If you have another one or can get another one ready, I'd appreciate it. FF is fragrance-free. So remember that if you have irritation already, inflammation already of your skin, we all like to smell good, right? You don't want to put a moisturizer on that smells like cow dung. But fragrances are very irritating. And so this has no fragrance in it. And ceramides. It's a double win. So that's one of my very, very favorites. But you can't tell someone, it has a brand name of Curel, right? You can't say, oh, go get some Curel, because Curel, like Aveeno, like Neutrogena, has 15,000 different variations. You have to literally write down Curel Advanced Ceramide Therapy. You have to put the actual name down, or they'll be confronted with an astonishing array of products that have that name at the grocery store or at the pharmacy. And again, no financial interest in any of this stuff. Okay. Also remember, you have to think about diabetes, hypothyroid. We're going to talk about systemic diseases as a cause of dry skin and itching a little later too. Okay. So, xerosis, dry skin, common in the elderly, a major cause of itching, but there may be others, and that's where we're going to go from there. So, things you can, rash that you can identify, scabies. You know where scabies itches all over, it's a hypersensitivity. But where you see the burrows, where the mites have crawled in the skin, you see little excoriated papules. If you don't have it in the finger webs, as you see here, and the wrists, it's not likely scabies, those most common, and in a male, you might see itchy, bumpy things on the penis, particularly the glands, or on the scrotum. So scabies. Now, who do we think about getting scabies? Young people, because how is most scabies transmitted? Close, intimate, personal contact. And most of your 92-year-olds aren't having sex. Most of your 24-year-olds are doing it as much as they possibly can. Treatment for scabies in the United States, permethrin equipotent, equally recommended to oral ivermectin, the difference being the FDA has not approved oral ivermectin for scabies, although the CDC recommends it. And I put the doses up there for both of those things. Is there any way to get another advancer? And this thing is really annoying. Okay, here's a patient. This is a picture I got from a patient who had some serious problems with her acne and now looks beautiful, as you can tell, thanks to my administration. She says, I'm scratching my head raw. Can you see me soon? She's 18. Scratching her head raw. What might she have? Lice. Yes, lice. Now, scalp itching equals head lice till you prove it isn't. It could be psoriasis, it could be seborrhea, but always think about head lice. Children in particular, more prone to head lice than adults. You may find the lice, but if you want to look for actually finding the lice, if you take some rubbing alcohol, put it in the scalp, it paralyzes them, it stuns them for a very short period of time. Quickly use a fine-tooth comb over a piece of white and you'll probably get a louse or two out. It's also a very interesting demonstration. Please kill them after that, however. That's the nit. That's the egg that the louse lays on the glues to the hair shaft. So look how small it is. I've left the person's thumbnail in there with the nail polish on to show you how small the nit is. So you have to look. If there are 5 million of them, it's pretty easy. Always look above the ears and in the back at the occiput. Good places to find them. There are lots of louse treatments. Because this is primarily a pediatric disease, you want the treatment to be approved in the youngest age possible. One of these has recently lowered themselves down to 6 months. They got approval. So you have a variety of things. Malathion, Ovide is the brand name, is 6 years. It's also flammable. So if mom puts this on while she's smoking a cigarette, you will eliminate the head lice along with the hair of the child. Not a good idea. Stings and burns, it's really a lousy product. Oh, no, pun intended. Okay. Now, here's the problem. We've had over-the-counter treatments for head lice for a very long time. The problem is that the lice have developed resistance. In fact, this is just recently published, they didn't check West Virginia or Alaska, but they had multiple sites in all the other 48 states, and they looked at the lice, they examined them for inherent resistance genes. That doesn't always translate to clinical resistance, but it's a pretty reasonable correlate. And other than the state of Michigan, go blue. I'm a Wolverine, go blue. Other than the state of Michigan, every other state had at least some resistance. There were 5 states that had some lice that were completely resistant, some lice that were partially resistant. But other than Michigan and 5 states, all the rest of the ones, 42 that they checked, the lice were totally resistant to what you would ask your patient to go get over the counter. Nix, Rid, pyrethrin, permethrin-related products. So that's a problem. Resistance is a real issue now in the United States, and that's the map they didn't check. Now, let's say you prescribe one of those other things like topical ivermectin or topical spinosad. You prescribe, and you have a mom who looks at you like this, and I've had plenty of them. Is there a natural way? Well, I actually like the Nuvo method. The Nuvo method was subject to one very good study. It proved quite effective, and it involves using something that's very complicated, Cetaphil cleanser. You put it on, you drench the scalp with it, use a hair dryer to dry it. That becomes a concretion, a mess, a hard mess. They sleep on this hard mess overnight. Then you use dishwasher detergent to get the stuff out, because that's what it takes. You do it once a week for 3 weeks, and it's virtually 100% cure. It's Cetaphil. It's not harmful. It's not an insecticide. How does it work? It asphyxiates the lice. That's what it does. This is my other caution, because we think of head lice as a disease in pediatrics with young children, right? And that's where it's predominantly. But the curve is shifting to older individuals, particularly young adults. Why? Because they're doing this. This is true statistically in the last 5 years. The mean age of head lice patients has gotten older and older and older, and it's now hovering around college age because they're all taking pictures, putting their heads next to one another. Not only are they getting nice pictures, they're passing head lice between themselves. It's wonderful. It's good for business. You're going to get a little preview of what's coming next year, and this is called Abametapir. It's a brand new molecule, and you can look the mom or look the patient, if it's a young adult, in the face and say, this is not an insecticide. Insecticides traditionally impair neurologic functioning of the insect, and this doesn't. What it does is it blocks metalloproteinases, which are not the same thing as neural. What those metalloproteinases do is they take the nit, the egg, and the part of it that opens, that lets the nymph out, doesn't open. So they never get out of the egg. But it's like the Ginsu knife commercial, but wait, there's more. It not only does that, it also interferes with metalloproteinases that are important for normal biochemical functioning in the adult. So it's both ovicidal, kills them in the egg, and pediculocidal, kills them while they're adults. It's a single 10-minute application, and it's very, very, very good. This is coming next year. Its brand name will be Xeglyze. And here's the other exciting thing. This is going to be brought to you by Dr. Reddy's. Does anyone know where that pharmaceutical house comes from? India. In India, they're very price sensitive. So the head of the company, the CEO, has promised he's going to price this like the OTC products. There'll be no resistance because no louse has been exposed to it. It's ovicidal and pediculocidal, so you don't have to worry about repeating it a second time to get the new hatchlings, and it's 10 minutes. And if it's priced as low as the over-the-counter products, this is a great advance in our treatment of head lice, which itch. Now, body lice itch too. Why do they itch? Because the louse comes on the skin, it bites. In its saliva are several proteins that induce itching. Then it goes back where it came from. Body lice do not live on the body. Body lice live in the seams of the clothes. I call them seam squirrels, but there they are. So this is the clothing that goes with that gentleman. Where is clothing in close contact to the skin, which facilitates the body louse crawling out, getting a blood meal, and then going back home? The neck, the axilla here, and at the waist. So if someone's itching in those areas, And their skin just shows excoriation or little red bitey things that are excoriated. Look at their clothes. Now, body lice are not common in folks who aren't down and out, but occasionally they happen. So that's body lice. And the treatment for body lice is to incinerate the clothing. This is another person, that's his clothing. Notice where he's itching, where the clothing is in close proximity to the skin. Okay, fungus infections, tinea this and tinea that. The number one thing I want you to remember is, generally speaking, fungus other than the palms and soles tends to make round things that are scaly. But not everything that's round is ringworm. Remember, lupus is round, granulomannularia is round, sarcoid can be round. Lots of things can be round. But round and scaly and itchy, think fungus. So this gentleman who happened to have a fasting blood sugar of 352, he presented because of his rash. Diabetes promotes inherent immunodeficiency, and that promotes things like fungus infection. So diabetes, immunosuppressed, immunocompromised individuals, more prone to this. In the United States, 95% of all fungal infections of the body, the hands, the feet, the face, are going to be due to Trichophyton rubrum. One organism is predominant. How do you treat it? Anything you want's fine. Any topical antifungal works. Big meta-analysis showed that that's true. Some work quicker, but they all work in the end. Pick one, use one, doesn't matter. If it's so widespread it's not really feasible to use a topical, oral terbinafine 250 milligrams once a day, rare side effects. For a couple weeks, takes care of almost everything. The gentleman with the fungus, notice how the active ring, it's more active at the periphery than in the center. The guy with the fungus all over his chest was a medical student. He came up to me after my elementary lecture on fungal infections of the skin, lifted up his t-shirt, and he said, "Do you think I have a fungus?" I said, "Yes, you do." Medical student. He's now a neurosurgeon. In Louisville, don't have any neurologic problems in Louisville. I mean, if you let yourself go to this extent, I'm sorry. Tinea Rx or crotch rot, it still has that annular, more active at the outside than in the center. All these tinea things. Tinea pedis it's not usually annular, it's usually scaly in between the toes, particularly 4 and 5, and then it can get all over the bottom of the foot, look kind of like a moccasin. It itches, it's scaly. Not so red on the feet as it is on the body or in the groin. Notice the outside. That's, if you want to do a potassium hydroxide prep, if you're used to doing them, if you've been trained to do them, that's where you scrape. You put a couple drops of 10 to 20% potassium hydroxide on, go see another patient, go back, look under the microscope and find fungi. So you look at the edge, or if you need to send a little culture off, that's where you find the fungi, not in the center, at the edge. And that's what you see under the microscope, and there are all the fungi. Okay. Any topical will work. Now, there are a few tips I can leave you with. So here's tip 1. Luliconazole is a relatively new antifungal. If the insurance allows the patient to get it, because it's on the expensive side, it's the only one that's once a day for a week. Once a day, 7 days, done, for tinea of the body, fungus of the body, and fungus of the groin. And by the way, it doesn't matter if it's fungus or yeast, it's very potent against both. So if it's candida in the groin, it'll also take care of it in 7 days. Yes, 7 days, exactly. There's 7 days worth of treatment. Hallelujah. It's very nice, but expensive. So here's the other side of the coin. Patient has no insurance or crummy insurance, and they have a fungus on their body, on their feet, on their hands, anywhere. Butenafine is an allylamine. It's in a different class. It's not an azole. It's like terbinafine, an analog of terbinafine. Butenafine used to be a prescription drug called Mentax. It's now over the counter. It's $9 for a tube that would treat this entire room. It's a gigantic tube for $9, over the counter. Walgreens, CVS, any pharmacy has it. But it's called Lotrimin Ultra. It's very confusing because Lotrimin's been around forever. That's clotrimazole. And there's lots of resistance to clotrimazole because it's been around since the 1970s. But there's virtually no resistance to butenofine at all. So you have to write Lotrimin Ultra if you're recommending this. You have to circle the Ultra and tell them it'll be right next to the Lotrimin. Don't take the Lotrimin, which is a few bucks less. Take the Lotrimin Ultra. But $9 for a gigantic tube is a really good way to treat tinea, cheaply. Other tip about itchy, scaly, round things on the face, that's tinea faciei, is almost always in an adult or a child, particularly in a child, due to a new pet, a new puppy or a new kitten, that they're going like this, oh, Muffy, you're such a cute little kitten, and they get fungus on their face. When you see round, scaly things that itch on the face of a child, usually it's around Easter or Christmas. They've got a new bunny, a new puppy, a new kitten. That's what it is. Any topical you want will take care of this, and then you microwave the animal. I was joking. Don't microwave the animal. You send them to the vet. Their bill at the vet will be probably larger than their bill to see you, but that's neither here nor there. Other things that you relatively diagnose. Psoriasis can itch. I'm going to talk about that in the next slide. And lichen planus, purple polygonal papules, can itch, readily diagnosable. 70 to 90% of psoriasis patients itch. Interesting. We think of this, the heartbreak of psoriasis being red, scaly plaques that everybody sees and recoils from. But it's really itch is an important component. And here's a little clue. It's a great clinical pearl. Aspirin, not NSAIDs, not all of them. Aspirin is unique in that it relieves the itching of psoriasis. Standard dose, aspirin. Interesting. Don't know why. Atopic dermatitis, usually rash in the flexures, like the antecubital popliteal fossa in an adult. In a toddler, infant, it's going to be on the face, on the cheeks, itches. And then allergic contact dermatitis. Someone came in contact with something and now they itch. It's acute. It hasn't been going on very long. The location and the shape tend to tell you what caused it. Does anyone have any vague idea what caused the contact dermatitis I'm showing you on this slide? A Band-Aid. If they've been out messing around with plants, it's poison ivy. Depending on where you live, poison oak, poison sumac. They're not uniform, but poison ivy's all over the country. Okay, and I just want to make this point. If somebody's pregnant and they suddenly become itchy, now they may ask their OBGYN or they may ask you if you're their primary care healthcare provider. So there are rashes of pregnancy, that's a whole hour lecture, that itch. Most rashes of pregnancy are benign, but there are a couple that carry a bad prognosis for the fetus, and one that even carries a potential problem for the mom. So itchy rashes in pregnant women really need an expert look. And often that should be the dermatologist, not necessarily even the OBGYN. The most common rash in pregnancy that itches is pruritic urticarial papules and plaques of pregnancy, PUP for short, and that one's fairly benign. By and large, it's the most common, but there's some other ones that are very, very important to make the proper diagnosis. So itchy pregnant women should see a dermatologist. There's a good reason for it. So this is a quote from this group called the Flaming Lips. And the summertime will make you itch, the mosquito bites. Oh, great. Song was called Buggin'. Weird. Okay, so I wanted to point out, don't forget the obvious. Itching can be due, you have an itch, you have a rash, can be due to insect bites, right? All sorts of insect bites. You can't tell the difference by looking at the bite, generally speaking. P.S. Bed bugs are still alive and well in the United States. The epicenter, New York City. Please look in your headboard and look in the drawers of your nightstand. I've actually found bed bugs in hotels. I'm not saying anything bad about the Westin, but just always check. Okay. Now, how about itchy patients who have a rash, but the rash is kind of like, I don't know what that is. It doesn't look like anything I'm used to looking at. So this is an important one. It's called Scabies Incognito. So it doesn't look like itself, but it's scabies, particularly in the elderly. All of these are scabies. Look at this one. If that patient came into you and she said, I got an itchy ear, and you saw that little bit of, would you think scabies? It's very atypical. But this is so common now that I want you to remember what's in red here. Any elderly patient presenting with a new onset, I don't know what the hell this is, it doesn't look like anything I've ever seen or heard of, rash, nonspecific, should be assumed to have scabies. And the treatment, either oral or topical, is fairly benign. And you may look for metabolic reasons, we'll talk about in a second, but if you don't find anything, but they have this rash, and it's sort of, I don't know what it is exactly, then think about scabies. Now, we talked about scabies before as a sexually transmitted disease. So how does someone, that woman whose ear I showed you was a nursing home patient, she's 88 years old or something like that. How did she get scabies? Is she running around with a 92-year-old guy at the next bed? No. Who gives it to them? Their caretaker, their nurse, their relative who comes and says, oh, grandma, I just had hot sex, I got scabies. Grandma, you know, that's how they get it. Or, I mean, you know, it's possible. So, you know, scabies in an adult. Older adult, too. Anything that itches, think about scabies in an older adult. Okay, other things. Just think about the environment. They should, if you have a sort of, I don't know what this is, sort of non-specific-y, it's all over rashy thing. It could be from anything from fabric softener to the clothes they wear. Avoid things like heat. Don't wear wool, wear cotton, stay cool. Don't use soap that's harsh. Probably the least harsh soap made in the world is called Vanny Cream or Vanny Cream bar soap. It's a really, really good soap because it has nothing in it. Not a very good soap, but it'll get a few scales off, but it has no fragrance, it has no preservative, it has no masking fragrance, it has nothing in it that patients are allergic to, and they hold it in their hands and it's a bar and it kind of lathers, so they think they're using soap. It's close enough. Okay. Meds, of course meds can cause itching, some more than others. Non-specific rash, widespread, always think two words, drugs, viral. Drugs, viral. If they're on medications, every medicine has itching in their PDR, in their package insert. It's itching. But some can really do that, so think about medications as well with a non-specific eruption. And then there's this thing. It is diagnosable, but it's basically an itch that rashes. It's called Prurigo nodularis. This is someone who itches, and they itch so much, so intently, and they pick and itch in individual spots that they now have bumpy things there. And if you biopsy those, they're full of hypertrophied nerves, which are sending itch, itch, itch sensation. Prurigo nodularis, lumpy, bumpy, itchy things. And this is really, really difficult to treat. The best treatment is to freeze it with liquid nitrogen pretty hard, and then also inject it with triamcinolone acetonide suspension, 10, 20 milligrams per cc, pretty concentrated. And you may never know what started it, but it's a result of chronic itching. And the patients will even say this. They're not going to hide it. Yes, I pick at that. I scratch at it because it itches. And they're right. It does. So you have to really destroy the suckers. And there are other treatments that can be used. Sometimes this prurigo nodularis can be a sign of undiagnosed renal insufficiency or may be related to significant anxiety that requires intervention. Now, the interesting thing we know now is that the patients who develop these hypertrophied nerves and these hard, rock-hard, itchy things, it's actually mediated by a very specific subset of nerves. And if you block those nerves, you block the itching sensation and their prurigo will get better simply because they don't keep picking at it. You may still have to destroy the individual lumps, but they won't get new ones. And the way to block that is with a nutritional supplement that's over the counter, that's dirt cheap, N-acetylcysteine. What happens is the cysteine comes off of that molecule, displaces the glutamate in the nerves, and the nerves can't fire anymore. It's very inexpensive, and for Prurigo nodularis, it's a very good supplement. You start off, they either come as 500 or 600 milligrams in most pharmacies and grocery stores, health food stores. You start off at one of those twice a day, either 500 or 600 twice a day, and you can titrate up to about 4,000 plus milligrams a day, whatever it takes, so that they say, these don't bother me anymore. Then you freeze the living daylights out of them, and they go away, and you're done. If you just freeze them and inject them, you might make some go away. They'll still pick at them, they'll come back, or they'll make new ones. So this is a nice basic therapy for this very vexing itching situation, Prurigo nodularis. Then there's this, endogenous unclassified eczema. I call it itchy red bump disease because this is what it looks like. Nondescript, non-scaly, small, dermal. So there's no scaling on the top, there's no blistering, there's nothing on the top of the skin. They're deep, they're hard, they look like little peas under the skin, buckshot under the skin, and they itch. And we don't know what causes it. The biopsy is very, very helpful because it's quite specific. Shows lymphocytes and eosinophils, but it's not a parasite, it's not a drug. We think about those things when you see eosinophils in the skin. It's neither of those. Biopsy is very typical, and the only thing that helps this really is prednisone, unfortunately. But, here's the but. There's always a but. As my daughter says, there's always something. So, before you start calling this itchy red bump disease or essential dermatitis, remember HIV. We don't talk much about HIV anymore, but you know, we still have 50,000 new cases a year, every year. So this is not an unheard of disease. And about half of HIV-positive patients itch. And they may have an itch that's above the nipple line or below the nipple line. People have tried to separate those out. They're probably all the same thing. An itchy rash with HIV positivity. If someone's at risk for HIV, think about it. And they're itchy. And I'm going to show you examples. This is eosinophilic folliculitis. So if you biopsy, what do you think you see? You see eosinophils around hair follicles. Look at that. That should make you think about secondary syphilis, because that's a typical manifestation of it. But that's HIV. It's a rash associated. It's not the acute eruption of HIV, which is very, very nonspecific. They've been HIV positive for a while. These are HIV positive patients with a pruritic rash. So always think about HIV. I like this. Gilda Radner said, I base most of my fashion sense on what doesn't itch. That's pretty cool. Okay, they have no rash. What are you going to do? Think about these definable entities. Renal and hepatic failure. Thyroid dysfunction can be hypo or hyper. Either can itch. Hypo probably a little more common because it induces xerosis. So that may be a bit of a problem. Diabetes. My dad and his brother married my mom and her sister. Two brothers married two sisters. And so that aunt and uncle, they were my favorite aunts and uncles out of very, very many. And my uncle presented with intractable itching with nothing on his skin. He had diabetes. That was his only manifestation. No polyuria, polyphagia, polydipsia, nothing. He itched. So think about itching as a potential manifestation of diabetes. We're going to talk about cancer in just a second. Parasites, drugs. Here are some of the systemic diseases that have been associated with itching. And 10 to 20% of systemic diseases will itch. And these are the most common. Notice Hodgkin's disease. So enlarged lymph nodes in a young adult who's itching. Hodgkin's. So proven otherwise. Some drugs, you can look at this list on your own, a variety of drugs. What do you do with the itchy patient who has no rash? Here's a reasonable workup looking for some of the things that can do this. TSH is a screening, hemoglobin A1C or fasting glucose is a screening for disease. LFTs is a screening for hepatic disease. HIV in someone who may be at demographic risk. Hepatitis serology, maybe. Hepatitis B and C both can present with itching. Stools for ova and parasites, especially if they had travel history. What about malignancy? I always get that question, can someone itch because they have cancer? And the answer is yes, they can, but the odds ratio is a tad over 1.3, except for two things. One is bile duct carcinoma, or something that's occluding the biliary tree, or lymphoreticulaire malignancy, like Hodgkin's, non-Hodgkin's lymphoma, cutaneous T-cell lymphoma. Cutaneous T-cell lymphoma is going to present with skin. It's the Hodgkin's and non-Hodgkin's that might present to you. Weight loss, I don't feel well, etc. And then polycythemia vera, especially when they take a shower. Take a shower, hot water, I itch. Get a CBC, which is part of my workup for the I don't have a rash, but I itch. This guy presented with itching, and he has a pleural-based bronchogenic carcinoma. Heavy smoker, but no symptoms relating to his lungs. No cough, no hemoptysis, no nothing, just itching. So yes, it can happen, but it's uncommon, definitely uncommon. Look at this lady. She's an 82-year-old. She resides at home. 20 years ago, she had breast cancer. She takes some medicines, but they've been long-standing. She suddenly looks like this, and she itches. She itches all over. But I'm going to show you her in juxtaposition to another 80-year-old. What do you notice is the difference? Yeah, she's jaundiced. So she's itching. She has no rash, but she's jaundiced, and she's older. And so she got a CT-ogram, scanogram, and she had pancreatic cancer that was blocking her biliary tree. Okay, last but not least, itching. No identifiable etiology, no real rash. Think of two things. If they itch between or at the bottom of their scapula, that's called notalgia paresthetica. If they itch on their arms, that's brachyradial pruritus. Those may be associated with spinal abnormalities. Let me show you what they look like. Why do they have a brown spot where it itches? Because they've been scratching and scratching, and they have hyperpigmentation from the inflammation there. That's where this entity is, and the other one is on the dorsum of the arms. So these are localized. If there's a gross defect in the vertebral spine, that needs to be fixed. TENS units work pretty well in this situation. This patient's in a nursing home. She's scratching. She's got excoriations. Has this been going on for a short time or a long time? Look at her. Long time. Why do you know it's been going on a long time? Because you see all these areas. That's from having scratched and it healed, right? So that's an important thing. And she has dementia. And remember I told you earlier, the loss of inhibitory fibers because something's wrong in the brain. This can be anything from a brain tumor. I actually found two in my career that with glioblastoma that presented with itching, but with nothing else. So one of the things to ask is, vision, headaches. Do you have any? Oh yeah, I have some headaches. Oh. So it can be brain tumor, it can be post-stroke, it can be Alzheimer's, dementia of a variety of types. So think about a neuroconsult if you have itching and no rash. There may be something there. Always think of scabies first. And then last but not least, I don't know what the hell's going on. They just itch. I have no idea. Watch out what they wear. Watch out how much heat they come in contact with. There are holistic ways to think about doing for them, particularly support groups, maybe behavior modifications, stress or anxiety reduction. Acupuncture actually has worked for these itchy patients. And then last but not least are drugs. All else fails, give them a drug. This is the list of medicines that have been used for I itch, I have no rash, there's no metabolic reason for it that's definable, and I have no idea what to do. These are the two statistically that work the best. except naltrexone has a lot of problems with dizziness and other things. So really, paroxetine, that's Paxil, is a good drug for I don't know why the patient's itching, but I need to relieve them. This one works as well, efficacy, but it has more problems with side effects. Azathioprene's been used. Oh my God, this is a wacky study because there's a high dropout rate because there's a high degree of adverse events. But when all else fails, if you want to give someone 150 milligrams of azathioprine and nausea and it's something else you might think about, but not a good one. Last thing, last slide, aprepitant. This is Emend, brand name. It's used for nausea, for chemotherapy and also postoperative nausea, but in relatively reasonable dose, 40 milligrams twice a day, it actually will inhibit chronic itching of unknown cause. The problem is cost, very expensive, hard to get approved for itching, so you have to say they're getting chemotherapy. Well, you can't lie, of course. Well, sometimes. Anyhow, that this is another thing. All else fails. Paxil's my kind of fallback on drug, paroxetine, but if that doesn't do the trick, and I have no idea, and I've turned them upside down and backwards, this is another option, and it does work well for itching of chronic disease. Ogden Nash said, happiness is having a scratch for every itch.